So just before we start that, can I ask HQIP whether you've got any conflicts of interest? Because we haven't actually, I think, had anything from you on that.
We have no conflicts of interest.
Sorry?
No conflicts.
No conflicts of interest. Perhaps you'd be kind enough just to write that into us so we've got a record of it, because people do ask us, so that would be good. Right, so I'm Julia Cumberledge, and I've been invited by the Secretary of State, the former Secretary of State, to do this review. When one is tasked with an issue like this, the first thing you do is try and get the very best people around you, advising you, and I have that. So Sir Cyril Chandler is on my left, and many of you will know Cyril, and he knows many people within the NHS. On my right is Simon Well, and Simon has taken particular responsibility for communications, which, as I have said previously, is really important to us. On Simon's right is Dr. Valerie Brass, and Valerie is secretary to the review team. And on Cyril's left is Sonia MacLeod, Dr. MacLeod, who is our principal researcher. So that's us. So then I'm going to ask you if you, because it's going to be on the record, if you could very briefly say who you are and the position you hold. That would be helpful. So should we start with you?
Yeah, so I'm Dr. Manpreet, Pujara. I'm a GP. I work for NHS Digital as the Clinical Director for Patient Safety and Clinical Governance. I also have a role as a lead at ICCG, leading on prescribing and GPIT.
Right, thank you very much indeed. Yes, thank you.
I'm Stuart Harrison. I'm the Head of Safety Engineering for NHS Digital, work for Manpreet.
Thank you.
I'm Jill Stoddard, Operations Director at HQIP.
Right.
And I'm Sasha Hewitt. I'm an Associate Director at HQIP.
Thank you.
I'm Keenan. I'm the Medical Director at HQIP. I'm also Associate Medical Director at Manchester University Hospitals. I'm seconded 2 days a week to work with HQIP as Medical Director.
Thank you very much.
Good morning, I'm Matt James. I'm the Chief Executive of the Private Healthcare Information Network.
Thank you.
I'm Justin Keenan. I work in the Faculty of Medicine at the University of Leeds.
I'm Julia Lake. I was, until a month ago, the Clinical Information and Outcomes Manager at Leeds Teaching Hospitals. I'm now working with the EHR Electronic Health Records team.
Right. Thank you very much indeed. I'm going to start with a question and just say that one of the things that we've been tussling with to some extent is about definitions, so that we really know what we're talking about. And I think it was Voltaire who said, if you wish to converse with me, define your terms. So I'm going to start putting this question to you and just asking whether you agree with this. Because we have been thinking a lot about our terms, and particularly what is a registry. Secondly, what is a database. And when we have been talking to people, there seems to be some confusion about these two terms. So I'm going to read this out, and I'm just going to ask each of you if you agree with this definition, because we really need to get this straight. So, this is the International Medical Device Regulations Forum, and this is what they have suggested is a registry. An organised system that continuously and consistently collects relevant data in conjunction with routine clinical care, evaluates meaningful outcomes and comprehensively covers the population defined by exposure to a particular medical device or devices at a reasonably generalized scale, e.g. international, national, regional health system, with a primary aim to improve the quality of patient care. So I hope you think we know what we're talking about now when we're talking about registries. A database. This is the Oxford English Dictionary. A database, a structured set of data held in a computer, especially one that is accessible in various ways. And we're thinking as a review team, for our purposes, it's in relation to mesh. Such a database might include the NHS number, the type of procedure, the operating surgeon, the healthcare provider, the unique device identifier, the date of procedure, the age of patient, and the gender. Does that sound right to you for a database? Okay, so when we're talking about databases, that is what we're talking about. And when we're talking about a registry, it's something much, much fuller and more difficult, I would suggest, to establish, but very important that we do. So if you have queries on that, and after perhaps you've had a bit of thought, if you could let us know, that would be very good. So I'm going to ask, first of all, Digital and PHIN, and I have to say it's good to see you here again, Matt. Thank you for coming. We don't appear to have a clear understanding of how many people have been affected by the interventions. We're talking about Prinodos, sodium valproate, and surgical mesh. So can you enlighten us at all about how many people you think have been affected by these interventions? Do you have any statistics on that, material, anything to help us on that?
So I think...
Should we take Primodos first? Should we go through the three? Primodos, do we have any information on that? No, all right. Thank you. Sodium valproate.
So I think that we have figures as to the number of women of childbearing age who are taking sodium valproate or who have taken sodium valproate in the past, based on statistics available from BSA, so it's proxy, and also could be based on information from GPIT systems in terms of repeat prescribing.
Right. So you may want to write to us on this, but what sort of what is the amount roughly? How many?
So I think it's really difficult because this is a figure that I didn't bring with me to have and it would not even be an educated guess for me to suggest what that number is. I think it varies. What I can do is I can put it into perspective so that when I did a search, an audit in my own practice of 14,000 patients about 3 years ago, we had 14 women of childbearing age who were taking sodium valproate.
Right.
So the numbers from a practice perspective isn't huge, but obviously the total number will vary. And within my CCG, the work that we've done also shows that there is variation within practices as to the number of patients taking sodium valproate because valproate is used for a number of clinical indications. It will depend on the population.
Yes, I think we're talking about childbearing age.
Yes.
Particularly, yeah. Because we had a debate in the House of Lords on Thursday and people were banding about different figures. Now we would like a bit more accuracy on that.
So I could certainly take an action to provide those figures to you.
Thank you, that would be helpful. Surgical mesh.
So again, I don't have figures. I'm not an expert in the surgical mesh work that has taken place, but it may well be that colleagues are able to provide some details about this.
So is it possible then that you could write to us as to
I certainly will
what
take
do you think?
action.
That would be very helpful.
Yes.
So if we haven't got the exact figures, if we haven't got, and we'll never get it exact, I mean, I do appreciate that, because all the time things are moving. But we're just wondering, would a full retrospective audit be needed? Would that be helpful, a retrospective audit?
So I think that it would be helpful. It comes down to what data is available to do that retrospective audit on, and I'm sure that we can certainly have a look at the data collections that we make at NHS Digital to see what information we can gather in terms of the numbers involved. That does depend on accurate recording at each individual trust and each organisation, which includes obviously the private sector and what access we have to that data in that situation. And obviously the recording of data, recording of information for mesh may also be taking place in primary care if and when the details are provided accurately and the general practitioner is able to code that information. But this will not be happening in a consistent way across certainly the 7,500 practices within England.
Okay. Can I ask PHIN also, if I could ask you, do you have any statistics from the private sector?
I'm afraid the short answer would be no, and that's for three principal reasons. The first is simply time frame. So PHIN is mobilising now to be in a position to collect data systematically across private healthcare on the same basis as the NHS, and to be able to do that in the future, which may help in any future scenarios like those that the review is looking at going forward. But we simply don't have anything that came from the time frame when most of the incidents arose that you've been looking at. The second issue is that we have very much a secondary care focus. So whilst vaginal mesh might fall within that scope, the other medicines and so on that you're looking at are much less likely to. And the third issue is that the way that we collect our data, which is really aligned to the principal ways that it's done within the NHS, very much has a procedure focus. So we wouldn't look for vaginal mesh itself. We might look for stress urinary incontinence, and if it was recorded that vaginal mesh was a feature of that procedure, a procedure undertaken to relieve stress urinary incontinence, then that may be recorded. However, what the reliability of that would be within NHS data and going forward within our data, I think would need to be tested.
And I just asked, wouldn't the private sector have the capacity to do a retrospective audit?
Well,
or capability?
So I think there are two things. I think if you look back at NHS Digital's data for stress urinary incontinence, provided that the related diagnostic coding was accurate, you would be able to make a reasonable estimate from that general data of the number of cases of the use of vaginal mesh. It would only ever be an estimate, but it would be a reasonable estimate. In terms of a retrospective audit, speaking very frankly, and I might be completely sort of out of school here, I'm not sure how that would be done other than going right back to original patient's notes or doctor's notes, because I strongly suspect that the level of detail doesn't exist recorded in the system that one could easily access in order to be able to do that in any sort of centralised fashion. I might be completely wrong, but...
No, you're right. It would generally be held on a number of different databases. So your mesh components might be in your stock inventory system, patient details elsewhere with your events and patient procedures. So generally it's fragmented. Things are in different places and it's very rarely joined up all together.
But there are other conditions where we have a registry, and it is very helpful to have those figures. And because we've been going around the country, we've obviously heard a huge amount from the patients who have suffered deeply from particularly surgical mesh, but also sodium valproate and also Primados. And we are conscious that trying to actually get a handle on how many operations are done and how many result in complications when it's mesh and disabled children in the other two conditions is very difficult for us. So the more help you can give us on this really would be very much appreciated. I think the data set would, help us. It's quite strange in a way that this hasn't happened in the past. It seems to have taken us an awful long time to actually get to grips with this situation. And there's a lot of learning, I think, to be done by that. Because the thing that patients certainly are saying to us at the moment, we feel that we are actually a clinical trial. Why wasn't this done before? And the speed of coming to understand some of these issues has been glacial. It has been awful. So I'm going to pass on now to Stuart.
The reason that we raised with you the definition is because we've been rather confused about how different people have looked at this. So can I just go into this in a bit more detail? What we're exploring is the notion that there could be a centralized database collected at the point of the surgery. When we attended the workshop, we raised this proposition, which would have the necessary information centrally held and created by the person doing the operation, not by a third party, using the NHS number, which would then enable us to build registries connected to it and around it. Now, can I ask you whether you think that's something that you would think is worth exploring? Perhaps ask all of you. Go start with NHST.
So I think it is something that is worth exploring because we do have other registries which are effective. I think the key is that it needs to be mandated because, and I'm not an expert on IG in GDPR, let me just say that the patient consent to whether they want their information on the registry.
Can I interrupt you at that point again so that we don't get confused? The proposal, which I really do wish you to your review about, is that it might be possible under legitimate usage on whatever section you're talking about to mandate, if you like, that information to the database. But as I understand GDPR, and I could be wrong about this, to create a register does actually require the permission of the patient under opt-out or whatever. Therefore, the registry would be a secondary event which the patients would then agree to. In my experience, because I've been involved in a registry, the European Dialysis and Transplant Association registry 30 years ago, patients are only too pleased to agree because they want to improve the outcomes. But Dr. Pujara, is that a reasonable proposition?
I think so, yes, because I think recording of an event needs to happen for historical purposes and for legal purposes. So it is important that there is a record that the mesh has been inserted, and I think having a registry would be very helpful. The point that I was making was just that very much that you need to get the patient's consent for the additional bit to go onto the registry, which is what my understanding is.
Okay, I want to come back, if I may, to your breast implant registry in a minute, but can we turn to HQIP now and say, how do you react to this discussion?
I think basically where we are today is we've got a totally haphazard system led to quite an extent by scandal or whatever. So we have the joint registry, which you're going to hear about, which has been going for a long time. We've had other audits, whatever you might call them, for instance, the implantation of heart valves and pacemakers, which you could affect using your definition of registry, which have been going for quite a few years. Then, of course, we had the breast scandal, and that came along with a registry, and possibly that there's going to be something with mesh. We leave that to the side for a second. But if you think of the devices being implanted today into human beings around England, there's enormous amount of stuff going in, cataracts, stents, every area of surgery and interventional medicine is putting things in, and there is very, very little information on these. So the idea of developing a registry to do with devices is a good idea, but you have to actually say, well, what is it you're wanting to do? Are you wanting to do device surveillance, which is on the safety area? Are you wanting to look at outcomes? And I suspect that's what patients, they would want both of those. And mesh is a really good example of outcomes, because the outcomes actually are very far out. So where does the registry finish? And indeed that, in your definition, which we will answer to, with the data set, outcomes weren't mentioned, and yet outcomes going on out into the future is really important. And actually the example we have of the joint registry, you probably saw the thing in the news a week or two ago, which incidentally didn't have the NJR in it. It was an international look at joint registries, giving outcomes up to 25 years for survival, etc., of joints. And then on the other hand, to do the outcomes, we actually stuck on to the National Joint Registry patient outcomes like death, which actually wasn't a very good coupling together, because death at surgery is
yes, I understand that, and it does actually talk about meaningful outcomes in the international definition, but at the moment the distinction that I'm seeking your reaction to is the notion of creating a database to which properly designed registries to deal with all the issues that you raised, which I absolutely agree with, and not least because I have a heart valve myself, it's that distinction I'm after.
Yes.
In principle, are you comfortable?
It has to be yes, because you'd say, why haven't we been doing that so far? It has to be yes.
Indeed. Before I turn to Matt, I must declare an interest because I'm a non-executive director of PHIN. Matt, your reaction?
Well, I'm in huge agreement with what both Danny and Manpreet said, actually. It is a totally haphazard system at the moment. I've been closely involved in the breast and cosmetic implant registry. We work closely with HQIP over the last few years, and whilst it is imperative that we are able to collect the sort of information that will provide a much, much better look at these issues and protect patients in the future, the manner by which we do it I now think is critical, and I would really like to see not just another standalone problem-specific, device-specific registry created, but a much more comprehensive look taken at how devices, medicines, and any other factors that are directly affecting patients can be universally recorded. I won't dive too much into the detail now because I'm aware of how short we are on time, but as a principle, that's got to be exactly right. In terms of information governance, I do completely recognise that a strong degree of mandation on various parties to do this would help enormously, because it has been PHIN's experience that despite the fact that we are very clearly legally mandated to do things, we must interact with other parties, including our partners NHS Digital, including the consultants who must review their own data before it's published, who are not legally mandated to do those things. And the process of obtaining permission or obtaining an end-to-end pathway of lawful basis to proceed is extraordinarily complex. It would also be my observation that currently every single registry takes its own bespoke approach to consent and confidentiality, and if you go down the consent route, you're very much pushed into being extraordinarily specific. And the particular situation you could easily create is one in which a patient has to review 3 pages of closely typed text that says, yes, I consent to this particular, my data being collected for the purposes of analysing this particular drug, and for those purposes and no other purposes, and then turns the page, and then for this particular device it's been implanted into me, and then for this particular outcome measure in respect to the surgeon's performance, and so on. They can have to sign 4 or 5 different consent processes, each in ignorance of the other quite deliberately at the moment. We must find a better way through that.
Yes, well, we are seeing the rare disease register and the cancer register related today. Professor Keenan, you've got huge experience in this area.
I have some, thank you. Do you want to just go first, Adrian? I'll come back to you.
Just on that matter of consent, actually, I just did a little bit of analysis yesterday to look at for the cosmetic breast surgery. I looked at our HES data against what our consultants had submitted based on consent, and it was only 40%. So you're admitting 60% of patients with implants because they haven't consented to it. And that
I understand the consent issue, but I just at the moment would like to concentrate on this issue about the difference between a registry and a database. Are you comfortable with the conversation we've had so far? Professor King?
Sorry, thank you, Sasha. So perhaps one of the striking things, just looking at some of the oral and written evidence given to this team so far, is that there's a sort of, if you like, an outside hospital view. So I wonder if there's some value in actually noting a third term, if that's okay, which is a data warehouse, which would be familiar to people who work inside acute trusts, because that may be where you can reconcile your notion of a database and a registry. So in very simple terms, most trusts will have what you might call real-time systems, the systems that clinicians, doctors, nurses and others use on the ward for the direct care of patients. And then a data warehouse is, as it were, a very large repository that sits behind it, offline as it were, which takes data from the patient administration system, the electronic record system, and many other systems, so dozens, and but it's a sort of, if you like, it's an offline store where you can, as it were, take databases or subsets of data from the real-time system, so it's individual data sets, and then link them together. So one possible solution is to take data from, for example, the electronic record system, link it to data that are filled in on a slightly different database, possibly, but concerned with a specific mesh implant procedure, say. But they can be linked together in the data warehouse. And as far as I'm aware, most trusts.
Yes, I understand that, and also the need to make central and local. But I think what I'm proposing for the database, or we're proposing, is something much more like a central system run by NHS Digital, like the DVLA or something of that nature. I accept the need for local as well, and that links. But again, you've got the issues that Matt has raised about mandation, maybe under 251, and opt out, which is not the same as opting in through consent.
Could I perhaps just add one more thing then, which is that again, just looking at some of the evidence that you've received so far, one of the things that I think can be underestimated, particularly if you're in a regulatory or other national body, is the rather simple fact that you just really need buy-in from the clinicians on the ground to start with, otherwise this just isn't going to fly. So I'm happy to agree with you. It's just that I would emphasise the need to get that data capture, buy-in to clinical.
I absolutely agree. We've already put this proposal, as you'll see on our review website, to the President of the Royal College of Surgeons and the President of the Royal College of Obstetricians and Gynecologists, and they think it's a good idea.
So I just wanted to come back and say, being very simplistic about this, because I often find keeping things simple really helps. A medical device is like any drug that is prescribed. There is a legal duty and responsibility to record that information. And if that information is recorded, and it should be recorded in the clinical system that is being used by the clinician, then that information can be collected and used on multiple occasions as necessary, as defined, and as is legal to use to ensure that actually the care of patients is improved and safety is improved. And so being a simpleton, I would expect every medical device that is fitted is recorded. And actually some of that information will come to us at NHS Digital as the data guardians for England, and that information will be available for us. And that information can be released and accessed through the legal processes that currently exist to ensure that appropriate research can be carried out. And so that we only have to do this once, and we're not revisiting this and having to create multiple registries, because it's a do once and actually use many times. It's the principle of devices being like drugs, and an expectation that there is a full audit trail history of what has happened.
Thank you. Thank you.
I just want to ask about HES data, because what I understand from people is that it's not very accurate because of the coding system. What we're suggesting with the database is that it's actually done by the surgeon in the operating theatre or just in the building anyhow. So do you think that would improve that? We won't be duplicating, will we, HES data?
You should ideally only have to record things once.
Well, I do agree with you, but
and we will need to ensure that the systems that are being used, and it will be a transition, there is no doubt, that the systems that are deployed record the information of the call face and make that available to be used.
Could I join that? Essentially, if you produce a system that's easy for surgeons, as we're talking about, to use, they'll use it. But say, for instance, the cataract audit which we run today has something like a 60% uptake. And the reason probably is because it's not readily electronically available in the operating theatre. Now, if it's sitting there easy to use, then it will be used. And if there's, obviously bringing colleagues with us is the best thing, but there is a bit of mandation about this, and that would probably make it up 95-100%. But I think the ease of use, and then the other thing is it mustn't go into a black hole. It must be used back so that it is used by colleagues to improve care. That's the real catch for I think for colleagues.
Well, I think we agree with so much of what you're saying is to get it to happen. That is always the challenge.
Yes, can I just explore an associated issue? So let's assume the database that we're talking about, the kind of database we're talking about, does exist. Who should be able to access that database, and how would they go about it? Does NHS Digital have a view on that?
So at the moment, data access, I think, happens through Pujara's process data. Again, I'm not an expert on hygiene in DARS, but applications are made to the group to access that information. They are assessed, reviewed, and if legally allowed, that information is made available to the researchers.
Can I just say one very important group that would need to have access to that data through one are the patients. So patients, through the work that we've done, we held a stakeholder workshop, and patients very clearly want access to information about the type of mesh device that they've had inserted, for that information to be readily accessible to them, perhaps even via an email or something that they can keep for a very, very long time. Obviously, we need to make the data available to researchers and other third parties, but really it's the patient group.
Yeah, I think we completely agree with you. Should patients be able to enter information onto the database?
That's something that we did debate again through those workshops that we held, and very much patients, clinicians thought that patients should be able to directly enter their outcomes, so how they, symptoms and how they are doing before and after their procedure. That
would you agree with that? You don't see any problems with doing that?
I think there are other national clinical audits that I can think of who do that. So the National Early Inflammatory Arthritis Audit collects PROMs directly from patients. It provides patients with a secure login so that they can access that data themselves and record how they are doing. I think it's a very powerful way to follow patients on.
And what about manufacturers? What access should they have to this database?
I think manufacturers do need access to this information so they can improve. They already have access to NJR data, and that's I think one of the strengths of the NJR.
The governance system that sits around the NJR is very good and has worked for a decade, longer than a decade. So I think any system that we might be bringing in, we already have the template for relationships between the information being warehoused, etc., and industry having the access that they need.
Do manufacturers share their data with the NHS, with all these bodies?
I'm not sure if I can answer that. So I chair the indicator committee for NICE.
Sorry?
I chair the indicator committee for NICE. NICE has got a very good setup, and you probably could hear directly from them as to the linkage between manufacturers and well, it's mostly to do with drugs and new devices. And there are problems. There are problems with sharing data, though. And I don't want to give you a second-hand version of that. I think it'd be much better to give colleagues from NICE, who are intimately involved in that, developing guidelines and specifications for technology devices.
Mm-hmm.
Can I also just ask about the link with Yellow Card? So this is a question for anyone and everyone. How would this database link to Yellow Card reporting?
Sorry, I don't know what it is.
Yeah.
The concept around traceability of devices is good, and I completely agree with it. The aspects of giving patients the ability to register and so on is taken elsewhere in the digitisation efforts around the NHS. So again, it fits into other national strategies in that regard. In terms of a safety culture, it provides a more open and transparent view around devices, healthcare and so on. With regard specifically to the Yellow Card reporting system, that has a traditional function. I think the linkages with other databases or registries, as you define it, are technically possible, and the user view could be tailored depending whether it's patient, manufacturer or NHS or private access. All of these things are available currently. Not just
So do you have a system in place to share information or intelligence between MHRA and NHS Digital?
We do, yes. We have a data sharing agreement. And we
Is that HES data, or it can't be?
This will be patient safety related information regarding health IT systems.
But at individual patient level?
There are elements of the incidents that we work with that do have patient outcomes or patient details on them, but with regarding the
identifiable patient data?
No, not to that level.
So it has data, which is anonymised.
It's anonymised, but it's similar to HES.
Right.
We focus purely on the health IT
but
side.
It is anonymised.
Yes.
Yes.
Yeah. But does that include Yellow Card reporting? But do MHRA share Yellow Card reporting in any form with you?
Yes, so specifically around the health IT and devices area. I believe you've had John Wilkinson on a previous session, so that linkage is there.
Right.
So do you have an influence in ensuring that the Yellow Card system is more comprehensive, that it acts properly, that it is responsive to patients? Or do you leave that to the MHRA?
So maybe I should answer this one. We've been instrumental in engaging with MHRA and getting them to engage with the NHS app team so that patients can directly report the yellow card system. And obviously one of the reasons that I'm keen for the information about any devices being made available within the patient's record is so that there can be linkages, should there need to be linkages. And so we are working very closely to ensure that the yellow card option for patients will be simple, straightforward, and as Stuart has said, you've had NHRA come to your hearing, and I think the volume of reports that they are receiving as a result of allowing patients to enter information has significantly risen as a result of it.
Once the NHS app is in place, there's a yellow card reporting function that presumably pre-populates. That goes through. What then happens to that information? Is it stored within that patient's individual NHS app record? Because we've heard of patients submitting yellow cards and then they can't find them with a different number, things like that. So would that provide the patient with very identifiable stores?
So, again, I'm not working on that on a day-to-day basis, but what I would expect to happen would be a report to file off to MHRA with a note within the patient's record that a yellow card has been submitted. Now, what level of details is recorded in the patient's record, or indeed if a full copy of that report is available for the patient to review, I could find out what the plans are for this to happen. I don't know the answer to that.
In terms of where we started in this part of the conversation around who should have access to the database and who both input and read access, I'm just conscious that we've not heard from Professor Keenan or Matt James or Julia. I wonder whether you have any thoughts on it.
I agree with a lot of comments that have been made, particularly by HQIP colleagues, and certainly stress the importance of patients having access. A lot of the rest of it, if you like, within NHS issue, the information governance regimes are reasonable in general terms. So at least, again, looking at if it was an answer from within the NHS, then I would suggest it's current information governance regimes plus patient access would be a perfectly reasonable model.
So what we found with some places where we have an external database that our clinicians put on, usually through a secure portal, is that within the trust we don't have access to get that information back. So we have some audits where we have a lot of assurance around it, so the data doesn't leave our trust until it's been signed off clinically, it's been signed off for data quality, and all of those checks have been done, and then it gets uploaded. What we found with some registries is that it goes offline and we don't have that sense check internally for our consultants to say, actually, I'm happy with all of that, and it's not until it gets published later we think, oh, something was missing. So I think any kind of national database or registry needs the ability for us to re-extract our data, for us to make sure that, and we have a little period of validation to make sure that what we send is as good, complete and accurate as it can be. And the clinicians in our trust are very involved in that process. They like to have that reconciliation and that process in place.
Okay, thank you.
Could I just ask you, HQIP and perhaps Professor Keenan, we've talked a lot about registries. Can you just tell us what type of oversight you think they need and what sort of governance is required? You know, who should be responsible for commissioning it?
So the national clinical audits that HQIP commission on behalf of NHS England and the Gulf nations all have their own governance structure. So they all have a overarching project board composed of clinicians, health stakeholders such as local, and very importantly patients, patient groups such as charities. They have steering groups, sometimes increasingly so separate patient panels that feed into those groups. So they've got their own governance in terms of overarching oversight. So you're thinking about HQIP obviously manages those audits. We report any risks through to NHS England on a quarterly basis.
So we commission and contract manage the audits or registries or confidential inquiries, and we contract manage, so we appoint a host organisation that acts as a host to the provider team that manage the registry or audit, and we contract manage that provider team within the host organisation, and then we upwardly report to the funders. So in many of the cases it's NHS England and the Welsh Government that we would upwardly report to.
We have links, firm links between our outputs and CQC and NHSI, so that we have trigger points if the audit is showing something or whatever, that direct links are made between the audit results, the team leading it, and the regulators.
It sounds a very cumbersome system. I mean, is it not possible to streamline it, simplify it, make it more effective?
So I think that we were actually asked by the Department of Health in August to undertake a rapid piece of work around looking at the 3 societies that are currently in place that host mesh data, and that's around a sort of short-term interim database solution, because we are aware that it takes quite a long time to procure. Obviously, if there's a certain amount of money involved, we have to follow legal frameworks for procurement, so it can take up to a year to actually procure for a registry. Once the a favoured person is given a contract, then it obviously takes them a period of time to set up teams and the IT platforms. So for a registry to be set up from start to finish actually takes quite a long time, which was one of the reasons why I think the Department of Health asked us to undertake a rapid piece of work around looking at the feasibility of an interim database solution to sort of potentially suck data out of the society databases to start collecting from pre-existing repositories of data, and we are very aware of the time trajectories involved because we want to get answers quickly for people, obviously, but so we could think about what's currently in place, and then we'd have to think about for our registry actually procuring and commissioning a registry will take quite a long period of time to do because of the legal frameworks involved in doing that.
Can I just add to that? You have to remember that the systems we're using, we do use HES data a lot, but then say about 70% of the data going in is HES data, but 30% is bespoke. And actually it does take time. Now, as we move digital and get into much more comprehensive electronic records, that will be helped. But the other point you heard about validation is really important. So if one of these things fires off and such a hospital is an outlier or an individual surgeon is an outlier, we have to be 100% sure that that data is saying the right thing. That's why these validation exercises are really important. So quite a lot of the time is taken not just internally validating data, but comes up into the audit provider, it gets cleaned, so to speak, it goes back to say, is this right? So there is a lot of that moving back and forth to make sure that the conclusions that are reached are accurate.
So can we have a cockshy on how long this would take? First of all, to establish a database that's useful, and secondly, then moving on to a registry.
Are we talking about the whole thing, not just to do with...
Well, I thought we needed the database first to get the facts, and then...
Thinking of mesh or the whole...
I'm asking it in 2 parts. First of all, the database. How long, because clearly you've got to gather the information, and presumably it takes a bit of time to actually gather enough to be useful, and then drawing on the database we then have a registry. And I'm just asking, the first part, how long would that take? And the second part, how long would that take?
So for
Mesh.
just mesh, yes. So for an interim database, we have just given the report into the Department of Health. It's currently embargoed, and we are awaiting a decision from the Department of Health about a potential outcome from that. It depends upon what the decision is from the Department of Health about which potential model has been suggested that they would like to adopt. So if it's possible to actually run with using data from the current societies, that would probably take about a year to actually bring to fruition. That's a rough estimate. For a registry, I would estimate, because of the legal frameworks involved, probably from start to finish, it would take a year for procurement and commissioning, a year for a host organisation to set up the teams and the platforms and start gathering data, and then a year to get to a final report. So you're probably looking at, this is a rough estimate, 3 years to get to a final report for a registry.
But within that, and within your proposals, and obviously we're not asking to talk through what's currently embargoed, one of the issues about the databases, as we know, is that the reporting is, well, it's under-reporting on all three of them. Do you therefore have proposals for how that would be moving towards 100% reporting, even for the initial stage, which is the database?
I think that depends on a few different factors. So the first is whether or not what legal basis it's operating under, and whether or not this is mandated. So if perhaps, for instance, the Department of Health were to direct NHS Digital to collect data, that removes the requirement to gather consent, and obviously then it's a legal requirement for organisations to submit data. Even under those circumstances, there still needs to be engagement in order to get people to use the system. It's very easy to build a database, very difficult to get people to use it, and it does take time for those participation levels to rise. Even in national clinical audits that we've got, where you suck the data directly out of EPRs, it still takes considerable time to build up participation levels.
If you're sucking data directly out of EPRs, presumably that literally is just taking data out.
That
if you've got a unique device identifier for each device, surely that will enable you to pull a data set of where these devices are.
May I respond to that? I think what you've just said there could be the absolute key to getting this done very quickly. The question you asked at the beginning was, actually you set out in setting out the differences between a registry and a database, what the components of a registry might be. And every one of those was a component of existing data systems and parts of the patient record, with the exception of the unique device identifier. If rather than focusing on rebuilding information with all of its duplication, all of its necessity to build a database from scratch, we focused on the process of ensuring the unique device identifier is recorded in every instance, and specifically is recorded and entered into the patient's record. Then you would have a basis for finding the correlation between the use of a device and the patient in every instance, and it could be done quickly. If you mandate its collection on the ground, and you mandate digital to handle that data, for example, then very quickly you'll develop a picture of which devices exist in which patients. If, on the other hand, we choose to build a registry from scratch, I mean, the breast and cosmetic implant registry, I think, is up to 6 or 7 years and counting, and is not sort of, it's basically operational now in collecting data, but it's not fully operational in being able to analyse that and produce results. So that's an example. It doesn't necessarily mean that everything has to follow that pattern, but a far quicker way to this would be to make sure the device data gets into the patient record rather than creating.
That requires electronic patient records, and how close how close are we to having complete coverage?
We're not close. Stuart, I know a lot about. We are actually tendering for an EPR at the minute, and in fact I heard about it the other night. I think it's going to be the autumn before it comes out with the spec, and it's going to be at least next year. So we are quite a long way off. Like the first thing, having said all that, is to get the NHS number into any of these areas. We haven't got that at the minute. So if you had NHS number going in and a device identifier, you've actually, those two things will give you a fair bit.
The proposition that we're putting is that when the surgeon or the clinician fills out the operation note, which always happens, that it includes this information, certainly maybe the barcode of the device and the NHS number among the other things. And there's no reason that goes into the patient notes, there's no reason it shouldn't go to NHS Digital, no reason why it shouldn't go direct to the patient. And then you've got the foundation to do all the other things that are necessary. That is the proposition.
Well, we've come from, registries were invented in an era when things were recorded on paper initially. And two bits of paper can't talk to each other, but two electronic systems can. And if we focus on making sure that the mandations, the system of rules, the lawful bases and the imperatives to join up electronic systems exist, we can get to answer, I believe, far more quickly than if we continue to create what are effectively workarounds to the question earlier around clinical confidence in the quality of HES data. I don't think clinicians do have confidence in the quality of HES data because it wasn't originally designed as a clinical system and yet is increasingly used for clinical analysis. I would strongly prefer to see that we address the clinical quality of the HES data, which is one of the fundamental building blocks, precisely by ensuring that clinicians have input to it at the operational level, rather than continuing to create workarounds where we collect all of that patient demographic data, the operating details again in a separate system, in order to then be able to build upon it with a few additional data fields.
Could you tell us something about the breast implant register? Because I don't understand that. It's run by NHS Digital, isn't it?
Yes. So I'm really sorry to say that there are not on a day-to-day basis involved with that.
So why isn't it run by HQIP?
We weren't asked.
But wouldn't it be natural for it to be run by HQIP?
So
No, because we are data guardians for the NHS, and therefore by law we are able to keep that information.
I understand why you collect the data.
Yes.
In the way we've been discussing. Yeah. But why isn't the interrogation of the data and it's undertaken
so a request
through
needs to be made
HQIP
to the DARS team in order to access
there is a lot of history in this.
Yes.
And it's, we've already talked about clinicians and HES. Like, I'm not stepping out of turn saying clinicians and NHS Digital wasn't a great relationship either. Now, it's fair to say that it's miles better our relationships, and I'm talking as clinicians, with NHS Digital, and it's obvious to all of us that there should be one area warehousing data. We can't have this system, which we do today, of bits of data.
And HQIP, MHRA, NHS Digital, and any organisation that's directed at the patient safety ought to all be doing their job at linked.
We do talk a lot to each other.
Thank you.
Can I just enter another area now, because we are concerned with GDPR, and that crops up in all sorts of different situations and discussions. And I'm just wondering how the interaction with GDPR would work with a database or a registry as well.
Sasha,
Can you explain that to us?
A specialist topic. So you're wondering what the GDPR requirements would be of a database or a registry. So this is a really tricky one, because we have obviously GDPR, which is the data protection Act essentially, and all of the security arrangements that go along with that. But we also have the common law duty of confidentiality, which is basically what everybody's talking about here when we're talking about consent and the legal basis to collect this information. It's very easy, I say very easy, turn up the camera when I say that, but it's easier to find a legal basis under GDPR than it is to find a legal basis under the common law duty of confidentiality, is my experience as an associate director at HQIP. However, there are lots of, the GDPR is not brand new. The requirements within it largely have existed for a very long period of time. It's just more explicit in its requirements. So a lot of the things, like having a legal basis under GDPR, being transparent with patients, being secure, all of these things are really the same. It's just that its requirement to exercise individual rights is clearer. Organisations now need to be accountable and transparent in their processing. So we did in our report to the Department of Health recommend that whichever model they choose, there would need to be dedicated information governance resource available for whichever organisation is setting up an interim or a long-term registry to ensure compliance with GDPR and common law duty of confidentiality, because certain things would need to be done, such as a data protection impact assessment. There would need to be a data protection officer appointed, transparency documentation would need to be developed, any consent materials. They would need to apply presumably for a data security and protection toolkit with NHS Digital, which is the new IG toolkit. So there would be lots of requirements, but I don't think any of that is insurmountable, and it just takes time and resource. And certainly our national clinical audits managed to do that quite well.
Yep.
So I think it would be possible.
Why can't HQIP set up registries itself? Why does it have to go and get other people to do it? Because if you did it with all those things covered and you had a relationship with NHS Digital, which was transparent and open and proper information governance, and you deal with the opt-out and Section 251, why can't all that be linked in a sort of more efficient way?
So I suppose the easy answer to that is we could do that. We have got the right people who could do that. It's about resources and being given a remit to do that.
We have been thinking exactly along those lines, actually, because those same ideas have gone through our heads as well, as to just get on with this. Because of this.
I must be clear, I think the involvement of clinicians of all sorts and patients in this exercise is vital.
Absolutely.
But I don't see why it all has to be done separately.
To come back to that point, I think what the process that HQIP currently manages is an upfront exercise involving patients and clinicians in the design of the data to collect and the objectives of a registry and how it's going to set out its purposes. And there's an exercise which HQIP manage very well when they're involved at the back end of that, which is to ensure that there are correct processes for validating the data, checking the outcomes, and enabling the clinicians to be directly involved in validating those outcomes and then publishing the analysis. And there's this process in the middle, which is all about holding data, the consents around the data, obtaining the data, and shuffling it around the system. And whilst the front end and the back end really do need customisation to a medical specialty or a particular issue and need careful governance arrangements, surely we can find ways to standardise that process in the middle, so that unlike BCIR and PHIN and every other organisation that's been invented that's had to find its own way through the data protection rules and spend years doing so and face huge amounts of frustration and expense, it will at the end of the day be huge amounts of taxpayers' money spent trying to navigate a taxpayer-funded system around how the legal bases are managed. If we can find a single approach to that on a common data platform, a common data architecture, and a common approach to the way that we handle those issues of lawful basis and consent, then we'll be in a far, far better place.
But surely they apply across all the registries. It's a matter
everyone is bespoke currently.
But that's the point. Why?
Yes.
Well, I guess they're bespoke because they each of them are trying to collect different types of data from different types of specialities on different types of patients, and they all have a unique methodology, so they have to do that in a different way in order to collect the right data and produce the right outcomes. So certainly my experience of audits is one size does not fit all, and the best audits are the ones who are run by the clinical societies and organisations that deliver that patient care and can really drive the improvements at the end. But my experience is not one size fits all. I don't know, even within NHS Digital, you've got your clinical audit platform. I would have thought there's still a need to bespoke and tailor that, depending on.
I agree, but I think the key goes back to that my simple message earlier on, which is about just collecting it once, and there's that expectation, dare I even say professional requirement, that actually, that you're recording this information, and once it's recorded, it should be able to be used on a number of occasions, and it's about partnership working. And ensuring that actually you may have different agencies that are involved, but actually that you collect it all at once.
Can I just add that? I think you have to think about the national audits and registries. So a lot of the national audits are in chronic disease areas, and we're talking quite a lot more to do with devices and the sequelae from devices. And they are quite different. So if you were to think of something like stroke or heart failure, actually the requirements in there are quite a lot different to, say, a mesh registry or a joint registry. And it's possible in the latter area there is a spec that would cover quite a lot of what's required, unlike the chronic disease area where actually there's different bespoke areas that need to be looked at.
Absolutely, but I mean the overarching legal frameworks that govern they are the same.
That legally is.
So it would be possible to conceive of, obviously all registers are different. The one I was involved in was for children across Europe who had kidney transplants or kidney failure. I mean, obviously that's very different from, but they could all exist within an all-for-all framework that did all the governance, both legal and information governance, and link into the data collection systems and so forth. The whole thing could be integrated, could it not?
I think the answer is yes. Like we've grown this thing haphazardly as well, the whole programme. If you think of Mike Richards and cardiac things, they kind of came in with Blair, etc., with the death areas, and obviously that's how it all grew, and then we moved a lot more into chronic disease. But I think what you've come at, and probably it is time to look across the programme and say, well, what is common this, and there is, like certainly the legal basis is there, certainly. But taking it forward, yes, there are common areas in these for sure.
I very much like Cyril's word of integration, because partnerships is always a lovely, lovely idea. And we know that even in the best practices, may I say, partnerships break up, and they are very difficult, very time consuming. It depends really on the individuals involved whether they want to work together or not. And although I think it's a lovely idea, I really think it's not strong enough, and that we need to think of something different in order to make this really work. I don't know if you'd agree with that. Probably not. Okay.
Can I just take that point a little bit further? So, is there a problem in terms of getting to where I think we're all agreed we want to get to, the database and registry concept that we've described? There doesn't seem to be any dissent around the table from those here today. Is there a problem in terms of decision making and leadership? I mean, who's ultimately responsible for implementing the kind of thing that we're talking about?
Well, we've answerable to the Department of Health and Social Services, and obviously NHS England are very, very important in our work as well. In fact, the vast majority of our money comes from NHSE.
So in order for us to act, we would need to be given a remit. So currently we are waiting for a decision from the Department of Health or NHS England about a remit to do whatever and funding, and I don't know whether that's something that they would want to do through HQIP as an organisation or a different organisation. So those are the decisions that we are currently waiting for.
Are you putting pressure on the bodies concerned to come to a decision?
I'm not sure that that's our role at the moment.
No. We're answerable particularly to the medical directorate in NHS England. That's our close link. And obviously that with NHS England and I coming together, that's going to make that easier.
You see, from a layperson's point of view, it always seems to me that there's somebody else that you're passing the buck to. And, you know, that gets very, very frustrating. And I understand that Parliament was responsible for a lot of this in the 2012 Act, the Social Care, Health and Social Care Act, and I do understand all these different bodies. But anything that we can do in new innovations that actually supersedes all this and really gets to the grips and make it quick, make it understandable to people would be really helpful. And we need your help with that.
Well, we met with Steve Powers, the medical director, the other day. In fact, that he would be the key person, and he and Simon Stevens, to be honest, there's going to be money, have to be money spent, and it has to be that access.
So do I understand that you get your contracts in effect from NHS England, but the person to whom you're accountable is the Department of Health and Social Care, is that
No,
right?
so on this particular occasion for the mesh work, we were approached by the Department of Health to ask, because of our expertise at HQIP, whether we could undertake a rapid piece of work. So we said yes, absolutely, really important subject, we really want to be involved in it.
So it's an arm's length body, you're arm's length from NHS England, are you, not from the Department of Health?
So we're not an arm's length body, we're
Maybe
a
not.
charity. So we're our remit is through the contract that we hold with NHS England, and we have to go through procurement process to win that contract. So we are a small healthcare charity.
So we have a national clinical audit and patient outcome programme at HQIP. HQIP is the host organisation for that, and we have the headline contract for that programme with NHS England and the Welsh Government, I should say, as well.
May I speak plainly on this? Because I think Danny referred to some of these issues. So we're coming from the outside. What we're trying to do desperately is bring the private healthcare data into alignment with the NHS. The question that immediately faces you in doing so is, to which bit of the NHS shall we align? Because lots of different bits are going in lots of different directions. And that is what has drawn me and our organisation into trying to understand all of these different pieces. To the question that was asked earlier about why HQIP wasn't asked on the breast and cosmetic implant registry, the organisation controlling the overall response to that was the Department of Health and Social Care, who asked NHS Digital to run the registry end to end, probably slightly to the surprise of some of the people who were participating in it up to that point, because up to that point NHS Digital hadn't been greatly involved, and in fact the MHRA had been taking the lead in doing the work up. But I think it doesn't really matter what that particular provenance was. It's illustrative of the point that if we continue to have a bespoke response to each issue that arises, we will get a different answer every time, and we will end up still dealing with a multiplicity of projects at different stages with different governance arrangements and so on. And that's why, to come back to the same point, I think it's imperative that in framing recommendations, whomever is responding, whether it's Department of Health and Social Care or NHS England, there needs to be an understanding that a level of coordination and alignment to existing processes and existing governance arrangements would be extremely beneficial, whatever comes next.
Can I say this conversation, at least to me, has been hugely helpful, so thank you. Can I just move us to a different area now, because it particularly relates to sodium valproate. We don't actually know how many women of childbearing age are currently actually receiving sodium valproate. but there ought to be a way of establishing a register, given that we know where the prescriptions are going. And is that something that you could do, Dr. Pujara, through NHS Digital?
Yeah. So I think we do know the number of women who are receiving sodium valproate. I just don't have a figure to give you today.
Okay.
I must apologise.
How do you know that?
For that. Well, we know that from one or two areas. So a lot of our information comes from prescriptions that are being dispensed and claimed with the VSA. So that is primary care prescribing on the whole, with a small amount of secondary care prescribing where an FP10 prescription has been used. The information that we don't have consistently is about prescribing in secondary care. But bearing in mind that most sodium valproate is initiated by specialists, but actually the prescriptions continue at primary care, we can be fairly confident that the information...
So you can create a register linked to the NHS number. This is person identifiable information, because to know where the women are, you could do that.
So we could get the information from the BSA, who have the dispensing data and who are the holders of that dispensing data, and that would provide us with an NHS number as well as the drug and the history in terms of prescribing. Now, as we move to a more electronic system, so as you will know, traditionally prescribing has been computerised for the last 20 odd years, but actually the dispensing and claiming has not been electronic. And for the last 10 years we've been moving towards an electronic system called the Electronic Prescription Service, which means that we also have information about what is being prescribed and what is being dispensed. So as the NHS moves more and more closer to full electronic prescribing in primary care and dispensing in primary care, then the amount of information that we have available will be significantly richer and fuller, in the sense that you can compare what is being prescribed and what is being dispensed as well.
But you could start collecting that data now, even though you haven't got full EPS.
So we are not the holders of that data. The data is
with the BSA
transferred from the GP system to the spine, where it stays for a transient period, depending on the expiration of that prescription, and then goes to the BSA, or is discarded if the prescription hasn't been dispensed. So at the moment, we don't hold that data for an infinite period of time at all. So which is why we have to go to the BSA to find out the information about what has been dispensed.
Is there anything to stop you doing that then?
No, so again, not being an expert on data and hygiene, I would say there is nothing stopping us from doing that. We would just need to ensure that it was legal and whether we needed a direction to be able to do that.
But that gives us women of childbearing age, however, just several parameters, receiving valproate.
Yes.
That doesn't tell us the number of children born, does it?
No.
Can we do that?
So I think if you, so that would involve further linkages. So if you were able to determine which one of those women of childbearing age are pregnant during a certain period of time, and there's different ways of getting that information. But I think in today's world, the most reliable probably is from the exemption certificate that pregnant women have, because not all pregnant women now come and register with their GP when they feel pregnant. In fact, most of that is done by the community midwives and so on. So sometimes as a GP, I may not know that a patient is pregnant until they're well into their pregnancy, because they don't have the...
But technically, and there are issues of common law confidentiality and GDPR in this area, hugely so, to create a register of women of childbearing age who are taking valproate. There are very significant issues there, but technically it's possible.
Yes, so as part of the work that we have done with the GP system suppliers, GP clinical system suppliers in general practice, we have made available audits for all practices to be able to run on a daily basis to see how many patients they have, how many women they have, childbearing age and taking valproate.
Is that for all GP digital support systems?
Yes. So
System 1, Vision and EMIS?
All four of them.
Which is the fourth?
Microtest. We have a small number of practices. That was enabled in all four systems, I believe, last year. I reported in July to the public stakeholder network that was all up and running.
That's consistent across all the four suppliers?
Yes.
But isn't it important that we ensure that women are much better informed of childbearing age? Because if you wait to see whether they're pregnant, it can take a few weeks, it can even take up to months for those who don't want to come to antenatal classes and things, and the damage is done. And I wondered if you had any views on the pregnancy prevention programme, because it does seem to be that is not working very well at all. And we've had surveys that are done by the patient groups to show that it isn't doing very well. And we just wonder why it takes so long to update some of the healthcare IT systems.
Thank you for that question. So we have, again, worked with the system suppliers between December 2017 and last year to ensure there is a new, updated safety warning for any woman of childbearing age who is taking certain valproate, which not only warns the prescriber, the user who's issuing the repeat medication, the authorizer, about the fact that this is a woman of childbearing age, but it also asks specifically, have you checked whether or not this woman is on a pregnancy prevention plan, whether or not they've had a review by a specialist in the last year as to whether they need to continue taking valproate. So there is a set of questions that appear on the screen. And one of the things that we've done for the first time is encourage suppliers to ensure that warning is consistent across the four systems wherever possible, so that with the way the workforce moves within general practice at the moment, with 40% of the workforce being salaried GPs or locums, it's important that there is consistency in the system. And then we've also worked with the dispensing system suppliers so that when the woman is collecting her medication from the pharmacy, that they also do the checks. They also have a similarly consistent warning that asks those relevant questions.
What
so
can
the
you
system
do
should
then?
be working better.
Yeah, what can you do then to ensure that it is as near foolproof as we can get? Because we know at the moment it isn't. And we are very concerned that more babies are being damaged.
So I remain very concerned about what I would call alert fatigue amongst all of us, because we're using technology on a day-to-day basis in almost anything and everything that we do, and we are used to moving on, shall I say, on occasions, not necessarily reading. I think it's really, really important to ensure that clinicians, prescribers, actually pay attention to the warnings that are there, and that those warnings are not, the number of warnings are minimised to those that are relevant for that individual patient. So rather than, receiving unnecessary warnings which are not relevant for the patient, which then results in the clinician or user learning to switch off and ignore those warnings. And sadly, I've come across trusts that have actually switched off their warning systems because of alert fatigue. We need to ensure that those warnings are very focused in those specific circumstances, and to ensure that clinicians have a system, a way of actually discussing those warnings. And I would like to actually put the patient at the heart of this, but the patient can actually also challenge the clinician. So for me, when I have a high severity warning, not only is it a red warning, but the computer also beeps. And I have a habit of discussing every single one of those warnings with the patient, particularly if I'm overriding that warning as to why I'm overriding it. And that needs to become the norm. And I think what we need to enable, and I'm hoping that patients being able to access their records and more systems where they can actually look at the drugs that they're taking themselves and take charge of their care, that they will be in a position to actually ask questions. The key thing for valproate is at the initiation of the drug to ensure that the woman or teenager or child is aware, or their parent is aware in those circumstances, of the risks. But we're also now ensuring that those warnings are checked every time a prescription is issued. That's what we've enabled. And what we need to do is to ensure that it's a coordinated effort, and it is I'm going to use the word partnership again, between the patient, the practice, and actually the pharmacist, to ensure that they all understand why this drug is being prescribed, why it's being taken, and what action have they taken to ensure that she's not going to become pregnant.
One thing that strikes me is warnings are there for a reason. So how is it that trust can simply turn them off?
A very, very good question. I have no answer to that at all. I don't know, Stuart, if you want to.
Some of the systems are inherently configurable, and so that's the feature. And sometimes some clients will ask for that. I kind of agree with your train of thought that shouldn't be possible. And a lot of what Manpreet said is very much configurable to the clinical setting.
Right,
So
well,
none of the GP systems are configurable in that way, so those warnings are there. But what we can't do is control the user and the behaviour.
right, well, I'm going to draw this to close, and thank you very much indeed for coming. But first of all, I'm going to ask my colleagues if they have any further questions they want to ask. I want to echo very much what Sir Cyril has said, which is it's been enormously helpful to us. I do want to thank you. You're going to give us some more information that we've asked about numbers and things like that. And if there are other things that you think, oh my goodness, they missed out on that, we'd love to know, because we are very anxious to do a really good review. And it does depend on people like you who've got the knowledge and the expertise to help us do that.